I think with glaucoma, it just affects such a broad spectrum of the population. 2% of the population over 40. And then, as Professor King was saying, by the time you get to your late 70s, early 80s, it's as many as 1 in 8 or higher. Now that's a huge number of people who are sat in our consulting rooms day in, day out. And I think the challenge that we have ourselves is to make sure that we're really cognizant of it, but also reaching those people who may never ever have thought to access eye care.
Everybody they see, they should be asking, have they got glaucoma? Have they got a family member of glaucoma? Do they know what glaucoma is? If the answer is yes to any of those things, they should be referring them to the Glaucoma UK website, because we're always time constrained when we're having face-to-face, interactions with people. That Glaucoma UK website will answer most questions and provides a helpline for people who may not find the information that they're looking for there.
And I think that would be absolutely brilliant as a habit for us to get into as all clinicians, because it will just bring more people into the community practices, but also it'll really educate those people in the chair about it's not just a test of how well you can see. It's not just about getting contact lenses or the most suitable frames for you. It's about looking after yourself and those around you.
A key focus of our awareness raising activity is Glaucoma Awareness Week, which will be happening this year on the 26th of June to the 2nd of July. And we'll be doing a variety of things during that week. And our theme this year is My Glaucoma. And we're encouraging people to go on our website and just finish that sentence for us. Just maybe talk about their diagnosis or someone that they know with glaucoma and what it's like for them. And I think for most people, that sentence could easily read, my glaucoma was found at a routine eye test. So that's such an important message that we want everyone to take away.
The second thing is that we need to look at making sure that optometry services are well represented in more socially deprived areas, because ultimately if we're relying on case detection to identify people who have glaucoma, we need those opportunities to be in socially deprived areas as well as less socially deprived areas.
Glaucoma is the problem that we've all got. It is so prevalent, and with an aging population, it's vital that we get the core foundations to make sure that we can do lots of this management ourselves. I personally see it as a big part of our work in the future, alongside other services, but managing that glaucoma, we are the only people who can help with it. We are the only natural partner to secondary care in the community, because we have similar equipment, we have similar skill sets, and we can make a huge difference to local people that we serve for a variety of purposes, day in, day out, long into the future.
The primary challenge, I think, is the expanding need for us to diagnose and monitor patients with glaucoma. This is primarily a function of an aging population. This hasn't really happened overnight. This has been entirely predictable. We've known for many years that there will be a lot more elderly people who will require diagnosis and care at this stage. There has been no significant expansion of ophthalmology services to accommodate this. This problem has existed for many years, but of course it's been exacerbated most recently by COVID, which resulted in the shutdown of both primary care detection services and hospital and primary care monitoring services. So there's a big backlog now of patients who require glaucoma follow-up and monitoring and treatment as a consequence of that. There is no straightforward solution to that. Obviously we need to increase our capacity, both in terms of our ability to see and monitor patients, and we need to look at alternative ways of delivering care in terms of perhaps virtual clinics, so more remote monitoring with expert opinion, evaluation of that data. So if we can explore ways of expanding primary care opportunities to diagnose and deliver opportunity, as well as refining secondary care means of doing that, then we will try to develop a more efficient, and efficiency is the name of the game, with experts who are managing these conditions to increase our capacity.
To start, you need a nationally commissioned pathway. We've seen that with the changes in the NHS GOS contract coming in Wales, where you've got a nationally commissioned pathway which will allow more glaucoma patients to be seen and monitored in the community. So that's really great to see. Unfortunately, that's not the case in England. We've still got, I think as Professor King said today, a postcode lottery, and we need that consistency within services in England. And we're seeing it in Scotland as well, where we've got the NESGAT scheme coming out as well, and in Northern Ireland in terms of LES 1 and LES 2. So nationally commissioned pathway that really clearly defines what the roles are of the experts, so the optometrist, maybe clinical technicians as well as ophthalmologists. That's the key starting point. And then as optometrists, we should be getting ourselves ready, in terms of upskilling and improving our capability. So whether that's prof certs or higher certs or IP, as we know from the nationally commissioned pathways in Scotland and Wales, that is really important as well. So message to all optometrists out there, upskill yourself and start developing those capabilities. So when we do get those nationally commissioned pathways, we're ready as a workforce to deliver.
We all need to up our game to meet this challenge. And actually a big thing for primary care optometry is sending people in only when they need to be seen. Lots of that is doing the same tests as ophthalmology. Lots of that is upskilling ourselves, working with higher qualifications, but also conversing with ophthalmologists locally to find out what we can do to improve the outcomes, not just for them, but for the patients who we might never meet that would otherwise be behind others in the queue that needn't be there.